I'm Dr. John Bowman. I'm currently serving with OrthoVirginia as the Chief Medical Officer and the Chief Compliance Officer. I worked for many years in this group since 1991 as a foot and ankle surgeon and retired in 2013. During the 4 years since I retired, OrthoVirginia grew fairly dramatically. We have pain management physicians, mostly orthopedists, rheumatologists, anesthesiologists who do pain management, physical medicine physicians, family practice, sports medicine physicians. So we're all geared toward providing quality musculoskeletal care from an assortment of interdisciplinary perspectives. So all told, we now have 1,500 employees around the state working within OrthoVirginia. We are, as orthopedists, very much involved with Medicare-age patients in terms of total joint replacement. So most of our providers for this year see at least the minimum of 100 patients over $30,000 in Medicare revenue. So nearly all of us as physicians would participate in MIPS this year. We plan to include everybody who's eligible to participate. We get dashboards within Epic so that we can monitor each individual provider and coach and have a lady who spends a lot of her time getting the MIPS steps in place as patients are being registered and roomed. So we feel we can be successful for multiple providers. OrthoVirginia began working with HQI early in 2017 as we were beginning to plan for our Epic installation. We realized that we had a lot to learn. We had to learn a new system. We had to learn MIPS. They looked at what measures we'd met, how we have met them, how well we had done on that, where the opportunities for improvement were, where we were succeeding and probably didn't have much additional work to do. And we built upon that to move into the MIPS program as we were doing our build for Epic. How does OrthoVirginia plan to achieve success in MIPS? Is a very interesting question. We, first of all, have to combat the apathy of providers who think that since we're now group reporting, there is no need for the individual to perform because somebody else can do all the work and they'll enjoy the benefit. So that's a hurdle for us to overcome. And to help combat that, we do have individual dashboards and we have office managers that we're training to monitor the 5 to 6 physicians that might be in her office so that she can flag the underperformers early on and we can get their work routines and workflows corrected before we reach the end of the 90-day period that we're going to report in this year. Most people seem to think of each measure as being something that you can get a 90% and you'll be fine. Well, there's a lot of education that needs to go on about that. One has to approach it with the idea that you're going to choose measures that aren't topped out, that everybody's getting 99 percentile in, because you get points based on the decile in which your particular score falls. So if everybody's achieving at the 90% success rate, then if you're at 91%, you might only be in the 3rd or 4th decile, and you'll get 3 to 4 points for that. On the other hand, the BMI measure we chose, the people that were setting it up thought 90 sounded like a really great goal. But when we looked at the benchmarking data, which you can get from CMS, if one gets to 70% recording BMIs on patients, that puts you in the 9th percentile. So you can get 9 points for getting a grade of 70 in that measure, and then for entering all medications into the electronic medical record, one best be prepared to be at the 98, 99 percentile just to get 8 or 9 points. So one needs to take care to select measures that aren't topped out, that everybody's hitting a home run on, because you can't differentiate yourself from the crowd on some of the measures. I think the biggest challenge on the day-to-day is to get everybody to follow the established work cues that capture the data that's being used to measure performance on each individual measure. People slip into careless habits or think it's not important to do this today because we're running 45 minutes behind. So that's always a challenge. It's a challenge also to keep physicians motivated to be following their own dashboards as to how they're performing, so that they can be giving their staff positive reinforcement as to why we're doing this. I think one of the successes that we're going to experience here will be because OrthoVirginia has realized, and I've educated physicians, that once the current level of 0.5% increases in Medicare reimbursement go away in about a year or two, there is going to be no pay raise in the Medicare sector, with the exception of achieving success in MIPS. Since it's a revenue neutral law, and there are supposed to be 3 losers for every winner, it's theoretically possible to get a 12% boost in revenue. So when doctors start to think about a 36% spread in a company that may have at that point $120 million of Medicare revenue, that's real money. So I think that's why the program was put into place. It's to influence physician behavior, encourage them to do things that are public health oriented, population health oriented, and reap the rewards for doing a good job at that. So the challenge is there, and we hope we can step up to meet that.